Good morning. My name's Richard Hayes, and I'd like to welcome you to this session on behalf of the UT3C consortium, which I'll explain to you in a minute. There are, in case you don't know, there are 5 trials of universal testing and treatment in sub-Saharan Africa. They're called SEARCH, HPTN 071 PopART. SEARCH is in Kenya and Uganda. PopART is in Zambia and South Africa. And then BCPP is in Botswana. The TASP trial is in South Africa, and the MaxART trial is in Swaziland. All these trials are looking at universal testing and treatment as a means of controlling HIV, and that's in both women and men, incidentally. This is supposed to be universal. We're very proud that the PIs and the investigators on these 5 trials have come together to form a consortium. It's called the Universal Test and Treat Trials Consortium, or UT3C. And we are working together as a consortium to share our data, to work on joint papers together, and importantly, I think, to explore our findings in an attempt to understand the results of these different studies. In the session this morning, we have 4 talks, which will take the first hour of the session. There will be 1 talk given by a member of each of the 4 trials that are measuring the impact of UTT on HIV incidence. But unusually, although we will have a member of each trial speaking, each of them will bring together data from all 4 of the trials. And so this will be a comparative and collaborative exercise, which we're very, very pleased about. So first we'll have a talk by Joanna from TASP which will just briefly summarize the designs of these 4 trials, for those of you who are not familiar with them. Then Kalpana will look at how the trials are estimating coverage against the 90-90-90 targets and some of their findings. Then Shaheen from BCPP will look at where are the gaps in coverage. So it's all very well achieving the 90-90-90 targets, but are we doing that in all age and sex groups, for example? And last but not least, Carol from the SEARCH trial will bring together information on HIV-related stigma from the 4 UTT trials. After that, we will have a panel discussion, and at that stage we'll ask these 5 colleagues from all 5 of the UTT trials to come up on stage, and at that time we'll take general questions from the audience. I should mention that one thing we're not doing this morning, in case you came hoping to hear the primary results of any of these trials, they are embargoed until tomorrow at 11 a.m. When we will hear the primary results of the SEARCH, BCPP and MaxART trials. That will be in that main plenary hall. It's called the Co-Chair's Choice session, so I hope you will be there. So without more ado, again, welcome to this session, and I'm going to ask Joanna from the TASP trial if she'll come up and briefly summarize the design of the 4 trials. So if you just click on your presentation.
Thank you. Okay, good morning, everyone. So I'm initiating this series of cross-trial presentations by a brief report on one of the first projects that this UT3 consortium has worked on, which is to compare the main characteristics of the 4 UTT trials. So this work has been published recently in a paper in the Journal of International AIDS Society. And basically, what did we aim to do? So we aim to compile and to summarize, compare and contrast some of the main characteristics of the 4 UTT trials. Actually, the 5 studies at that time in that paper, the 5 are presented there, but today I'm focusing on the 4 UTT trials that aimed at impacting on HIV incidence. And why did we do that? We really wanted to better understand what each trial had meant by UTT, how they had defined universal test and treat, how they had implemented universal test and treat, and thus better understand the different similarities and differences in study results, and also really encourage cross-trial analysis. So how did we do? What were our main methods? So we did what we called a comparative assessment, which to do that we screened trial protocols, we compiled trial procedures, we accessed national guidelines, survey data. We also conducted key informants interviews with some of the key staff members, whether investigators or coordinators or even field workers. We also basically met over a year and a half period quite regularly to come together and decide together how to structure this comparative assessment and what main results to report on. And we opted for 5 main result areas, basically presenting the study context in which the trials have been implemented, the methods and the design, the content of the intervention packages and universal test and treat interventions, the themes and main secondary outcomes that had been investigated, and also some of the protocol adaptations and modifications that happened throughout the course of the trial. So in this brief presentation, it's going to be very much summarized and simplified. So I really encourage you to refer to the trial protocols and some of the trial publications if you want more specifics and more details on each of the 4 trials. So as Richard presented a few minutes ago, so this is a map showing you whether 4 trials were implemented and the countries that have benefited from these UTT interventions. So I won't repeat the countries, but just to highlight that throughout the presentation we've adopted, and actually throughout the whole session I think, we've adopted a color code to help you identify more easily which trial we're talking about. So yellow is for the search trial, red is for PopART, blue is for BCPP, and green is for TASP. So in order to give you an idea of the different study contexts in which the trials were implemented, so these next 2 slides are presenting some of the main characteristics of the populations within which the primary outcomes of the studies were computed, so HIV incidence. So we see here that all sites have been facing or are facing generalized HIV epidemics, with substantial differences, however, between some of the study sites. You see here for the search trial, the sites in Uganda, with prevalences ranging from 3 to 7%, whereas in South Africa or Botswana, HIV prevalence around 30%. Similarly, some heterogeneity in ART coverage at baseline among the different study populations, 30-40% in PopART and TASP versus 70% in BCPP. In terms of population profile, again, quite substantial differences. Very rural populations in the search and TASP trials, whereas BCPP included also peri-urban populations, and in PopART also urban populations. Differences in age also, with a median age of 40 in BCPP, which has the highest median. Differences, again, in level of education or employment. And one common feature, however, is the fact that the majority of the individuals included in the trials were women. In terms of objectives, so obviously each trial had a specific way of formulating their aim and objective and specific objectives, but what was common to the 4 UTT trials was their global aim to evaluate an impact of an intervention package and around universal test and treat on HIV incidence and at population level. And they also shared this similar aim around investigating the implementation of universal test and treat, around the acceptability, the feasibility of the interventions, the costs and cost effectiveness, in order also to provide evidence to decision makers, policy makers, when thinking about the scale up of universal test and treat for future policy and practice. So in terms of methods and study design, so all trials were community randomized trials, 2 arms or 3 arms in the case of PopART. Cumulative HIV incidence was the main primary outcome, and over 20 to 30 communities were randomized depending on the trial, and participants were followed up on average for 30 to 36 months. In terms of sample size or population size, variations between the trials, so the size of the population that was exposed to the trial communities, so overall control and intervention arm, varied between 28,000 in TASP to more than 1 million in PopART, and similar variations, large variations, in terms of the size of the population within which the primary outcome was evaluated. Now, when we look at the intervention, so this is it's quite heavy maybe on the screen, but it's quite simplified table and summarized, but it highlights the main components of the interventions that were investigated within the trials. And the intervention arm on the left and control arm on the right. So one common feature to all trials was the implementation of intensive HIV testing services, most often both in intervention and control arm. Immediate ART, however, so universal ART, was implemented only within the communities in the intervention arm. Search and BCPP also expanded the content of their intervention package by including comprehensive HIV prevention services, and also in the case of Search, multi-disease, so screening for HIV-associated diseases and non-communicable diseases. So when we look more specifically at the content of the intervention packages and the way they were implemented, which was obviously adapted to the local context and the need of the population, we see again differences appearing. For example, when we look at the model of care, so all trials adopted a home-based approach to implementing HIV testing, but some also opted for further intensifying and expanding the reach of testing by implementing mobile campaigns or generalized health campaigns in the community. In terms of delivering HIV care and ART, this was done mainly within government clinics in most trials, except the TASP trial, where specific trial clinics were implemented in each of the trial communities or each of the clusters. Now looking at the interventions that aimed at supporting HIV-diagnosed patients to access care and stay in care. So again, this very simplified table shows that some trials have provided more extensive services than others. For example, BCPP or Search provided various linkage and retention in care activities, whereas within PopART or TASP, they were more light touch on that type of intervention, less extensive. So one of the strengths of these 4 trials has been the fact that they adopted a multidisciplinary approach in understanding really the implementation of universal test and treat, and implemented several ancillary studies alongside the HIV incidence evaluation. So all trials have been exploring the successes and the challenges associated with the implementation of the trial interventions through mixed method studies, so quantitative, qualitative, different disciplinary approaches. All have been investigating and documenting community health, morbidity, mortality outcomes, as well as virological outcomes. All trials have also been documenting the economic impact of the trial interventions, to a certain extent of the trial themselves, on both households and local health systems. And also, all have been investigating the social outcomes associated with a universal test and treat, so which included the barriers, the facilitators to accessing HIV care, for example, or the community perceptions and experiences of universal test and treat. So one last issue we wanted to touch on was briefly some of the changes that were operated during the implementation of the trial. Sorry. So the main change was prompted by the evolution of the overall HIV policy landscape. So when the trials were initiated, the control arms were offered HIV treatment according to national guidelines, 350, 500 CD4. And by the end of 2016, Botswana, Uganda, Kenya, South Africa all had adopted the WHO Universal Test and Treat and immediate ART policy and guidelines, and thus the intervention and control arms of the 4 UTT trials switched to that universal treatment implementation as well. During the course of the trials, some have also adapted to different operational challenges that they faced in the field. And just to mention a few changes in the protocols or in the implementation of the services, BCPP, who initiated streamlined ART initiation and follow-up during the course of the trial, and in the TASK trial as well, the implementation of a linkage to care intervention in both the control and intervention arm after the beginning of the trial. So just to wrap up, so the main commonalities, the main similarities between the trials, all had HIV incidence at their primary outcome, all adopted a community randomized trial design, and all opted for really investigating universal test and treat and prevention packages through a multidisciplinary approach. Some substantial differences, however, in the scope and the intensity of the intervention packages that were implemented, both in the intervention arms and the control arms. So really keep that in mind when you hear about the main impact results that will be presented tomorrow. And finally, a few thanks. So thanks to all our colleagues that contributed to this presentation from the 4 trials. And thank you for Richard Hayes and François Labisse, who have led this consortium for a few years now, and really leading us into this collegial work that has been really quite fantastic. So thank you all.
Thanks very much, Joanna. We're going to take just a couple of questions, mainly of clarification, and then when we have the panel discussion later on, there'll be a chance to raise more general questions. So does anyone have any quick questions about Joanna's presentation? If not, then we will keep them for the panel discussion. So again, thank you, Joanna. And I'm now going to hand over to my co-chair and friend David Sawada, who many of you will know. He's from the School of Public Health at Makerere University in Uganda, and he's been very active in research in the epidemiology and control of HIV for as long as I can remember. So handing over to you now, David. Thank you.
Thank you very much, Richard. I'll quickly go on to introduce the next speaker, Kalapan. He's an epidemiologist at the London School of Tropical Medicine with a lot of interest in treatment Cascade. So he's going to present to us she is going to present to us the comparison of the 4 trials on how do they perform on the 1990 measure. Thank you very much.
Thank you, David. Good morning. It's a pleasure to speak on behalf of all my colleagues who have contributed to this talk on the strength of whose work I'm presenting today. Am I doing the slides? Are they loaded? Excuse me. There we are. Right, so my talk today will focus on the 2 main areas as identified in the title, the methods and the findings of the 4 community randomized trials looking at universal test and treat. And we'll look at the methods used by these trials for estimating coverage against the 1990 targets, and how these have been used as a way to measure the impact of the trial interventions, focusing specifically on the trial intervention communities. We'll look at baseline pre-intervention coverage and compare them with outcomes after 2 years of intervention delivery. We'll look at the findings achieved against the background of the methods used. There are 2 key considerations to bear in mind. All the trials have tried to get to the truth about coverage by looking at all available information from different angles, even different data sets. So what is presented today is just one of the approaches chosen so that they're fairly comparable across the trials. And some of the data is also based on provisional estimates. And as a result, what's shown here may differ from what you've seen published elsewhere or maybe published in due course. The targets, the 1990 targets, are presented above to remind us of the definitions for each 90 target, and the product of the three targets, 390s, equates to 73% viral suppression amongst all people living with HIV, as shown. Since their release, the targets have been helpful drivers to achieve high coverage, and they are intended to be cross-sectional measures of coverage, and ideally in a snapshot or in a short period of time, and to be population-wide. In the context of the universal test and treat trials, coverage has to be high in order to achieve the ultimate goal of population-level HIV incidence reduction. And the 1990 targets are a way to measure the impact of the UTT interventions on coverage over time. So looking at the targets then, if we start with the first 90, the starting point is the accurate identification of all people actually living with HIV to get the denominator for the first 90. And the necessary precursor, therefore, is the identification of all people living in the community. For the purposes of the UTT trials, this is all adults living in the communities, usually defined as older than 15 or 16 years. And the next few slides illustrate just some of the challenges of identifying this denominator population as accurately as possible. So if we're trying to identify all the adults living in the community, ideally we want to identify all households and all individuals living in those households. The reality of delivering interventions is that we've got to meet people face to face, whether that means finding them at home or having them turn up to community interventions, and they have to agree to participate in the intervention and hopefully go on to accept services being offered. When we're looking at the impact of intervention and comparing what was there before and the impact after intervention delivery, by definition then it's over multiple time points. And a key challenge with this is in the background over those time points, population flux occurs, deaths, out-migrations, and in-migration. So for identifying the target population we have, as a reminder, on the top row, I've got the number of communities we're looking at for each trial. From BCPP and Search, we're looking at all the intervention communities. For PopART, we're focusing on the Arm A communities in Zambia, which received the full PopART universal test and treat interventions. And for TASP, we're focusing on the 5 intervention communities which had 2 or more years of follow-up. So as we can see, all the trials performed community-wide enumeration at the start before interventions were delivered. At 2 years, the approach is deferred slightly. PopART and TASP field workers effectively conducted repeat enumerations during delivery of the household interventions, including updating information on new households, new household members, out-migration, in-migration, and deaths. Search also did a community-wide enumeration at their final year at the end of the study, and this data was used to estimate the year 2 population, because today we're looking at the results after approximately 2 years of the intervention. And with BCPP, for that latter time point, baseline enumeration data, which mapped all households, is actually still currently being updated using Google Maps to estimate population growth. So when we look at the adults reached by the intervention, bearing in mind this is provisional programmatic intervention delivery data, so we're looking at the proportion of adult residents reached by the intervention among all estimated eligible adults living in the community. As we can see, the underlying population sizes, the denominators varied, and at baseline, the population proportions ranged from 62% to 92%. And at 2 years, it ranged from 69% to what currently appears like as greater than 100%, but the explanation for that is, as I said, these are provisional data, and the denominator for the total population for BCPP is being re-examined by the team and will change once the estimates have been refined. So if we go on to look at what was required to extrapolate the information gained from those reached by the intervention to the total estimated population, we can see that the first three columns show what those first three trials did, and they all use similar principles. And the key assumption being that the HIV status and steps of the cascade among those not met during the intervention is the same as among those met before the intervention was delivered to them. For TASP, the findings I'm showing today are amongst those encountered and reached by the intervention, but they have done analyses elsewhere estimating the extrapolation to the total population, but they're not available today. So if we go on then, having understood the challenges in measuring the underlying total population and identifying all people living with HIV, we can focus on the methods used to identify the denominator and numerator of the first 90. So TASP were the only one of the 4 trials that did blood samples on all on everybody reached by the intervention in order to be able to determine HIV status. All the trials, as you might expect, had results of the rapid diagnostic testing. All the trials except PopART had access to public health records of people receiving HIV care as evidence that they knew the HIV status and therefore were seeking care. Self-reports of HIV status was used by all the trials except SEARCH. That was of HIV positive status, and self-report of HIV negative status was also used by BCPP and PopART, but not by SEARCH or TASP. And naturally, data on HIV, knowledge of HIV status from the first baseline round was used at latter time points. We go on to the second 90. All the trials except PopART had access to public health records of people receiving ART. Self-reported ART was used by BCPP and PopART, and we've already looked at how HIV status was determined, so I won't go over those again. Looking at viral suppression, so there's a missing column for PopART, and that's because our data on viral suppression is not yet available, not currently available. For BCPP, SEARCH, and TASP, you can see the definitions for viral suppression in the top row there, and SEARCH took blood samples on people identified as HIV positive to be able to look at their viral loads. All three trials had public health records, access to public health records of viral load monitoring results, and we've already looked at how ART use was determined. So if I go on to the outcomes now, with the exception of BCPP, these results are for interim coverage after 2 years, because most of the studies looked at the interventions followed for 3 years, but we're looking today at the 2-year outcomes. Whereas for BCPP, these are end of intervention coverage estimates using the programmatic data, as I've mentioned. So starting with BCPP, we can see that coverage, I think the obvious thing that stands out here is that coverage was already very high at baseline, but elevated even further after what was approximately 2.5 years. This is about 30 months. The resultant level of viral suppression going up to 85%. is obviously very impressive and would incidentally meet what would be aimed for if we were looking at the 2030 UNAIDS targets of 95, 95, 95 coverage. PopART estimates, we don't have data on viral suppression, as I've said, but we can see here the substantial increase due to the widespread HIV testing, substantial increase in knowledge of HIV status between baseline and after 2 years. And the resultant ART coverage as a result of the increase in knowledge of ART status went up from 45% to 71%. Go on to search. Again, after 2 years, you see the extremely high coverage reached by, in terms of knowledge of HIV status, and the resultant viral suppression of 76%, which exceeds the 90-90-90 targets, and 73% viral suppression. If I then conclude with TASP, who of course have already announced their primary outcome results last year, we can see the targets achieved by their trial, and also these results reflect, I think, the explanations the teams have provided in data we've already seen about the challenges around linking people into ART and how that impacted the primary outcome likely. So I'll conclude by summarizing. I hope I've illustrated that it is challenging to get accurate representation of coverage and estimate 90-90-90 at a population level, especially to measure the impact of interventions over time. And a key unknown in relation to this is the behind-the-scenes flux in the population. However, I think broadly estimates from all the trials indicate that high coverage is achievable. And it's worth noting that the 90-90 targets were not originally part of the aims of the trials. They were announced after the trials were planned, but they've been a very useful way of summarizing coverage. I'd just like to thank everybody who contributed directly to this presentation listed above, and of course everybody without whose efforts these results wouldn't be available today. Thank you.
Thank you very much. We would welcome any 2 questions for clarification. Yes, you go to the mic, please. Okay. Yes.
Thanks. I'm Donna Spiegelman from, well, here I'm probably best described as being from MaxArt. But I'm also from Yale University School of Public Health. And thank you for this very, very clear presentation. The thing I wondered about as somebody who's grappling with the MaxArt data is, I don't know if you can go back to the slide where you showed the cascades, even in just one study. That's good. So, it's beautiful in the sense of you'd love to teach this in a class where, say, the 7, 9, 8, 8 in the blue histogram are then in the denominator of the red. But in real life, at least in our data, I mean, there'd be nothing like that to be the case. So are you counting all people who couldn't be found as no's? And so these would potentially be conservative estimates, or how are you dealing with, let's say in search, I'm sure there were many people who there wouldn't be viral loads for, and so how were they counted and so forth?
Thank you for the question. I think the first disclaimer is that obviously I can't speak for all the 4 trials and the details with the results. Panel members might be able to. But for example, I can show here, if you see the denominator for the third 90, it is not the same as the numerator for the second 90, which in an ideal world it would be. As
but
you
in the
rightly,
others, I think they were.
Yes. So I'm afraid I can't comment on the estimates for each trial. For PopART, I'm very sorry, you've got the double asterisk there and the footnote that went with it. I must have deleted accidentally, and that actually does refer to this very idea that this denominator, in contrast to the numerator for the previous 90, is amongst those who are alive at the time and of the measuring the second 90.
Yeah, so I just might suggest as a conservative approach, you might actually use the denominator even if the people aren't found, under the assumption that if they're lost, they either died or are no longer being followed and so forth, and can reasonably assume to be unsuppressed. But I mean, these are the methodologic issues that I think will come further down the road, but in the end, they're very important in terms of what percentages are reported.
Right.
Incidentally, we are planning a paper on this, so we'll hopefully go into all the details in
I'm
due
sorry,
course.
I will only have to take one more question in the interest of time. Nancy, and then I'm sorry, we'll have to cut it from there. Nancy, please.
Yes, thank you, David. I have a similar question, but it's more. I have a similar question, but it's more related to BCPP. And it's sorry. I thought that in one slide you said that they reached 100% for the first 90, but then in another slide it seemed like it was lower, like in 90-something percent. Can you clarify that?
Is this the 100% you're referring to? And I did explain there that, I mean, the BCPP team will be able to explain this much better than me, but what I understand is that the denominator there, if you see, that was estimated at baseline, the size of the population, and this denominator has yet to be fully updated. What we can say is that over 60,000 people were met by the intervention.
Right.
And whilst they're sort of re-looking at their Google Maps and the methods they're using to update the population size at the second time point. So obviously this is going to change, and I highlighted that as a very provisional.
I won't ask my follow-up because David's not going to let me.
Yes.
I'm very glad.
We are going to have a very lively panel discussion with all the representatives of the 4 trials here. So we shall dive into the more details of some of the Cascade. I can see the Cascade has generated a lot of interesting questions, but please bear with us. We will have this panel with all the members of the 4 trials. Okay. So, Lockman is the next presentation is going to cover what are the coverage gaps in the treatment. Lockman is an infectious disease epidemiologist from and an associate director of Harvard University Center for AIDS Research, and is the co-PI of the Botswana Clinical Trial Unit. So, what are the coverage gaps?
Thank you very much. Good morning, and I thank the organizers for asking our consortium to talk today about coverage gaps, which I will do on behalf of the UTT trials. I would like to begin by thanking and acknowledging the many people living with HIV who have participated in this research. Our fight against HIV and AIDS is fundamentally indebted to these individuals. The UTT trials provide a good opportunity to assess and compare both pre-existing gaps in coverage by the HIV care cascade at a population level in various settings, as well as the effectiveness of interventions in narrowing these coverage gaps. Today, I will provide an overview of the following from each study. First, the HIV care cascade coverage by sex and age at baseline and after at least 2 years of interventions, and a descriptive outline of other factors associated with gaps in coverage. It's important to note that I will focus on coverage by testing and treatment among persons with whom the study teams interacted, and will not be discussing some of the challenges the teams had with ever engaging subgroups of individuals, which is obviously very important, but beyond what could be covered today. Each study implemented specific outreach or services aimed at engaging men and youth, to varying degrees and with a variety of approaches. In addition, some of the studies tried to engage particularly mobile populations. I will summarize key aspects of the targeted approaches used. The studies did not focus specific outreach or interventions to engage key populations. I'll first start with the TASP trial. TASP field worker schedules included visits on weekends and in late evenings to increase the likelihood of contacting students and employed individuals, including particularly men. The TASP intervention also tried to reach more mobile populations through mobile testing. I'll be showing a series of slides, sorry this is not terribly fascinating but bear with me, of depicting coverage achieved for steps of the 90-90-90 cascade broken down by sex and age. This bar chart shows coverage by sex prior to interventions in the TASP trial, with coverage in men shown in blue and coverage in women shown in red. As you can see, men have lower coverage at each step of the cascade, with the largest gap between men and women existing for the first 90, that is, the proportion of HIV-positive persons who already knew their positive status. Ultimately, 20% of men and 26% of women living with HIV had undetectable viral load at the beginning of the study. This slide shows 90-90-90 coverage in men and women in the TAPS trial, now at the end of the study following the interventions. The incremental increase in coverage is denoted by the darker colored bars stacked on top of the bars showing baseline coverage, with overall end-of-study coverage levels provided by the numbers above each bar. By the end of the TASP trial, the gap between HIV-positive men and HIV-positive women with undetectable viral load remained about the same as at the beginning and relatively low at 6%. This slide shows the 90-90-90 coverage by age group prior to interventions in the TASP trial. Coverage in 16 to 29-year-olds is shown in green, in 30 to 59-year-olds in orange, and in persons 60 and older in red. Youth aged 16 to 29 had the lowest levels of coverage for each step of the cascade, with only 11% of youth versus about 1/3 of older people living with HIV virally suppressed prior to rollout of the interventions in the TASP trial. This chart shows coverage by age group at the end of the TASP trial post-intervention. As can be seen, gains in coverage were made for each age subgroup and at each step of the cascade. However, a substantial gap in the proportion of people living with HIV with undetectable viral load remained at the end of the intervention, with only 26% of the youngest individuals compared with 64% of those aged 60 and older reaching this overall target. In TASP, several sociodemographic factors shown here were associated with lower coverage. Importantly, individuals who migrated into and out of the communities were less likely to be retained at each step of the HIV care continuum. However, their overall impact on cross-sectional coverage was limited, as the effects of in and out migration balanced one another. I will now move on to the SEARCH trial, which attempted to improve overall health for all residents, but also went to considerable lengths to engage men and youth specifically. For example, the SEARCH team sought to engage men by offering services at locations at which men were more likely to congregate and at places and times more convenient for men, as well as by including non-HIV services. Similarly, the SEARCH team attempted to engage youth by conducting multi-disease campaigns to try to reduce the stigma associated with HIV testing and by providing sexual education and condoms. SEARCH also conducted mobile HIV testing to increase accessibility for youth compared with school or clinic-based testing. In the SEARCH study at baseline, we see a similar pattern of somewhat lower coverage in men compared with women at each stage of the cascade, particularly again with the first 90 knowledge of HIV status, HIV positive status. This translated into approximately 10% more HIV positive women already knowing their HIV status at baseline compared with men and being virally suppressed. As you can see, after 2 years of interventions in the SEARCH trial, coverage increased at each step of the cascade, most notably for knowledge of positive status. The gap between the proportion of all HIV-positive men and women with suppressed viral load decreased somewhat after 2 years of interventions, from around 9% to around 6%. Youth aged 15 to 24, who are represented again by the green bars, had substantially lower levels of knowledge of positive HIV status and of treatment initiation after diagnosis compared with persons 25 and older in the SEARCH trial at baseline. Impressive gains were made in 90-90-90 coverage in the SEARCH study after 2 years of the intervention, both by youth and by older individuals, with particularly remarkable gains in HIV diagnosis. While the gap by age in the proportions of HIV-positive persons with viral suppression narrowed following the interventions, it remained larger at 16% than the gap between men and women post-intervention in search. Several other factors were associated with lower coverage of the respective steps of the cascade in multivariable analysis of data from the search closed cohorts. Male sex and generally younger age were predictors of lower coverage for each step of the cascade, while mobility and certain socioeconomic factors were predictors for some but not other steps. Now I'll move on to the PopART trial. The PopART team also invested considerable thought and effort in engaging men, including via conducting community-based campaigns designed to be appealing to men, such as multi-disease screening at sporting events, outreach to places where men may congregate, such as certain workplaces, transport hubs, and working on weekends and evenings, and HIV self-testing of men via female partners. The PopART team also attempted to reach youth by conducting youth-oriented events in communities and schools, having youth-friendly corners, and including specific training in counseling skills relevant for adolescents and youth. PopART also tried to engage mobile persons by testing, for example, at fishing sites and transport hubs. And in Zambia, PopART workers reached out to sex workers at guest houses. This slide shows HIV testing and ART coverage in men versus women again, it's now a familiar slide, in the PopART study at baseline. Differences in coverage in men versus women appeared to be less in this population than in some of the other studies and settings. By the end of round 2 of the interventions, the gap between men and women with regard to overall viral suppression in all people living with HIV was slightly larger than at baseline, presumably due to even larger increases in the first 90 in women compared with men, and impressive increases in the first 90 altogether. As observed in the other studies, younger individuals in the green bars were less likely to know their HIV positive status at baseline or to have started ART after being diagnosed. This is again now PopART pre-intervention. Similar to the search team, the PopART team helped facilitate very impressive gains in HIV diagnosis. Because of particularly large increases in HIV diagnosis in youth, the gap in overall ART coverage between youth and older persons narrowed from around 24% at baseline to 16% after round 2 of interventions. Finally, moving to the 4th UTT trial, BCPP also included elements of the intervention that were designed to help reach and serve men and youth. For example, in order to engage men, the field teams had evening and weekend hours, visited markets, bars, and workplaces, and held events to attract men, such as soccer tournaments, mobile testing events with music, and weekend health fairs. To better reach and serve youth, BCPP tailored the timing, location, and nature of outreach with this in mind, adding year-round mobile testing to increase the likelihood of reaching young people who often worked in urban areas. In this slide, I present the cascade stratified by both age and sex. That is in a slightly different way compared with the prior studies. Coverage in youth aged 16 to 24 is again represented by the green bars, in persons 25 to 34 by orange, and in persons 35 to 64 by red. For each step of the cascade, the set of 3 bars on the left side shows results in men, and the 3 bars on the right shows results in women. You can probably see a now familiar pattern emerging, with the greatest gaps once again among young people, and for the first 90. However, this breakdown of the data shows even larger gaps in the first 90 and in overall viral suppression by age among men compared to among women. This is pre-intervention again. By the end of the study, very good progress had been made in closing these gaps by age and sex, starting to close these gaps, I should say, although cascade coverage was still higher in all age groups of women compared with men. Pre-intervention, mobile HIV-positive residents were significantly more likely to be viremic. In addition, 4% of persons assessed for HIV in the intervention communities were non-citizens, and lack of Botswana citizenship was associated with lower coverage. At their first encounter with the team, only 23% of HIV-positive non-citizens versus 84% of HIV-positive citizens knew their positive status. In conclusion, in all 4 trials, coverage of each step of the cascade was lower in men and in younger persons at baseline. We saw wider gaps in coverage by age than by sex. The largest gap tended to be in knowledge of HIV-positive status, the first 90. While these gaps persisted post-intervention in each trial, they narrowed substantially when a combination of approaches was used to provide services that were more likely to reach and or to be acceptable to men and to youth. It was thus possible to successfully reach, link, and treat many men and younger individuals using approaches that offered flexibility in timing, location, and type of services. Greater mobility, both in quote-unquote stable residence as well as in persons moving into and out of communities, was associated with lower coverage, as one might expect. It bears emphasizing that the gaps in a graphic represent hundreds of thousands of individual people globally who are not yet receiving effective treatment and whom we must strive to serve better. I'd like to thank the many colleagues from each study who generously shared their data and insights for this talk, Richard Hayes for conceiving of this symposium, the large phenomenal study teams, the funders, and most of all, the many study participants.
Any question for clarification? Yes, ma'am.
Thank you very much, Sheena McCormack from London. I noticed that the age bands for youth did differ a little bit on the slides, and I wondered if the group had come to an agreement about the age for defining youth.
Thank you. We did not actually, ideally, in an ideal world, we would have reanalyzed the data in a similar way for all of the studies, but there simply wasn't time to do that under the circumstances, but that would be ideal for any future cross-study comparison and probably necessary.
And can I ask just one more question?
Right.
When you were using public health records, were you using antenatal records as well as what was in the primary healthcare centres?
I cannot speak for the other studies. I can say that for BCPP, if women were tested through antenatal care and that were recorded in their outpatient medical record or their antenatal card or obstetric record, we certainly would have used that. But in general, we didn't go back to those registers outside of what a woman might have had herself.
Okay, thank you.
Thank you very much. Richard will take it up from there. I do the last one. Okay, the last... Caro is going to talk to us about HIV and related stigma. Caro is from he's a social demographer, and he has been working on the SASH trial.
Thank you. It's my pleasure to be here today to speak with you about research on HIV-related stigma across the trials. And there are very diverse questions being posed and diverse approaches being taken to the study of stigma across these trials. But if I had to boil down those questions into 2 main groupings, the first set of questions really have to do about the effects of stigma on test and treat. And the question broadly, does HIV-related stigma limit the effectiveness of universal test and treat interventions, and if so, how? And the second set of questions have to do about the effect of test and treat on stigma. So do test and treat interventions reduce stigma or increase stigma or in some way change HIV-related stigma? If so, how? So here's the order of my presentation. I'm going to be talking about PopART, research in PopART, then search, then the BCPP trial, and finally TASP in KwaZulu-Natal. So in PopART, an ancillary study has been funded to specifically investigate stigma, and they're pursuing 3 broad hypotheses about whether the PopART intervention reduces, increases, and or changes HIV stigma. And they're conducting parallel assessments of stigma across multiple perspectives and multiple populations, but using quantitative measures and qualitative measures that are comparable to allow triangulation of findings. And I'm reporting now on baseline estimates of different forms of stigma in people living with HIV/AIDS in PopART. And as you can see, among people living with HIV in the study population, baseline stigma was high at between 30 and 40%. And levels of stigma reported by people living with HIV/AIDS significantly differed between South Africa and Zambia, with many estimates higher in Zambia than in South Africa. And the PopART team also asked healthcare workers about their attitudes towards people living with HIV/AIDS in the study population. The highest levels of shame were reported to men who have sex with men and to women who sell sex. And these findings were particularly pronounced in Zambia. But the team would like me to let you know that these healthcare workers also said that they would not deny these groups HIV services. The team also asked healthcare workers about the link between health facility spaces and stigma, and actually engaged healthcare workers in illustrating maps of health facilities to describe where they thought clients felt more comfortable or less comfortable as they were seeking care. And this revealed some interesting findings that also led some of the health facilities to change the way that they organize services in order to reduce the identification of clients by their HIV status and reorganize and integrate services in some ways spatially. The team also investigated self-stigma or internalized stigma among healthcare workers and found that a significant proportion of healthcare workers in both countries are living with HIV/AIDS as reported by themselves, as reflected in these figures on self-reported HIV status. And the qualitative research that the team conducted revealed that there were significant challenges for healthcare workers themselves in accessing services. So especially professionally educated middle-class healthcare providers were quite fearful of disclosing their status to their coworkers and to their clients, and feared having their HIV status used against them by both. So there were a variety of strategies that healthcare workers were using to conceal their status. And the team said, there's really a desperate irony that the healthcare workers who are the face of HIV care delivery are themselves struggling to access care because of stigma. And this is not often talked about, but requires urgent attention. Moving to search, we are conducting longitudinal qualitative research in search, pursuing a number of questions, but overall to compare over time and across trial arms how the search universal test and treat strategy influences changes in beliefs, attitudes, and behaviors related to HIV, to inform adaptations, to assess consequences, whether positive or negative, and to elucidate the pathways of intervention action. And we've been doing this in 8 of the 32 communities in search in Kenya and Uganda, and we have been conducting annual interviews in 3 different cohorts and conducting focus group discussions and observations at community health campaigns every year. For this analysis, I'm presenting 3 findings from 3 annual rounds of interview data collected from 2 of the cohorts, the community member cohort and the community leader cohort. And this process began with team-based coding. Our data collectors are engaged in our analysis process. So coding of over 419 transcripts, not all at once, followed by inductive case-level, person-by-person, row-by-row coding that indicates a change in direction of stigma over time. And the final stage that I'm working on now is really an analysis of pathways of stigma reduction, including contradictions to those pathways in deviant cases. And I'm proposing from our data that there are pathways of reduction of stigma in search that would impact upon the dimensions of stigma and that are really being driven by some recognizable drivers. So what we see is among people living with HIV/AIDS, because of the efficacy of ART, a reduced fear of dying, an increased optimism, a sense of restored social value and role fulfillment through their productivity, being healthy. We see positive experiences with HIV status disclosure. Now, there were negative consequences to disclosure. These were particularly pronounced for women. We've published on this. But we do see, with widespread testing, disclosure events building up over time, and increasingly more social support and visibility and solidarity with other people living with HIV/AIDS. Search brought higher quality care closer to home. People started seeking care closer to home. They'd go to the neighborhood clinic, see people from their community, and recognize I'm not alone in this. And finally, the power of appearance, or the healthy body. Fears of infection, contagion, decay, death, sin are no longer elicited in many settings that would enact or trigger enacted stigma. And in some settings, it's no longer socially normative to stigmatize people living with HIV/AIDS. So to give you an example of this pathway of the power of appearance, in the baseline year, an HIV-positive woman in eastern Uganda said, "Some people like to laugh at us, the HIV-positive people. They say, that person is about to die. Dead bodies, you're dead people." This same woman, 2 years later, said, "They look at HIV as a normal disease and not complicated like it used to be because they see HIV-positive people looking healthy and energetic like them." Similarly, an HIV-positive man in Kenya at baseline said, "People say, so-and-so is nowadays on drugs, and can't you see how he looks? This issue of how he looks is what many are trying to avoid, and for one to disclose, he must be a very close friend." 2 years later, he said, "The community doesn't look down on me because the drugs help a lot. From the look of your body, you can tell that it's good. Most of the people who use that drug, their bodies are looking good." About the pathway of disclosures, an HIV-positive woman in Kenya at the baseline year said, "When I came here," she had just moved to a community, "I found that people really hide their status from the others. They would not want anybody to know that they are taking ARVs." 2 years later, this woman said, "Let me tell you, now people are trying to share their HIV status." A relative said, "HIV is all over. It is something that should not be kept a secret. Everybody has it. Everybody is on ARVs. People should just share their status." He's really open. Even the lady I'm staying with is very open about her status. And finally, about the pathway around it no longer being what we would say in the US politically correct or socially normative to stigmatize people, even if you still hold stigmatizing attitudes. An HIV-negative woman in southwest Uganda in the baseline year said, "I think it is brought about by prostitution and promiscuity. Do you think that if you're not disorganized, you get that illness? It is a disease that you bring upon yourself. It's not like measles that you just get." 2 years later, she said, "They no longer treat them badly because they came to know that the disease is for everyone, and you're not supposed to mistreat another person. How do you harass another person when you know that you're also like that? It's like getting measles." In Botswana, the BCPP team has been conducting a qualitative study on barriers to and facilitators to linkage to care and ART initiation. So not specifically a study of stigma, but a study which has revealed stigma. They recruited HIV-positive adult cohort members in communities randomized to receive the intervention package. They found people who were eligible for AIT and then purposefully sampled people who did and did not link to care a year later. They also interviewed healthcare providers in the same communities, conducting interviews and focus group discussions and following a phenomenological paradigm in their analysis. They found there were barriers identified in the setting of high ART coverage having to do with segregation of care and care delivery, and people felt inconvenienced and stigmatized by these separately designated locations and days of service, and this especially affected highly mobile people. Then there were individual level factors associated with stigma that were barriers, including non-acceptance of status, non-disclosure, lack of family support, and religious beliefs. Facilitators included support from providers, including via home visits, social support, and knowing the benefits of ART. Participants said that more men could be reached by visits to their workspaces and their social spaces, and that addressing the structural barrier of segregated service delivery could help reach untreated individuals by directly addressing stigma. Finally, in TASP, the overall research question was, did TASP, with its large-scale implementation of repeated home-based testing and mobile clinics, increase stigma towards people living with HIV/AIDS in rural KwaZulu-Natal, contribute to the normalization of HIV and greater acceptance of HIV, or contribute to these? The specific objectives were to measure the evolution of stigma perceptions at community level during the course of the trial and to assess factors associated with stigma perceptions at community level at the end of the trial. They used a broad social science program involving mixed methods, including repeated home-based surveys every 6 months, interviewer-administered questionnaires. The main variables of stigma perception were these. Do people in your community blame people for having HIV/AIDS? Do people in your community avoid people with HIV? The start of the trial was mid-2012 and the end was June 2016. And as you can see, there is evidence of an evolution of stigma perception and a decline over the course of the trial. The proportion of people who disagreed with the statement, people in your community blame people for having HIV, that proportion who disagreed with that statement significantly increased, and the proportion who agreed with it decreased over the course of the trial. Similarly, the statement, people in your community avoid people with HIV, between the start and end of the trial, the proportion of people who disagreed with that statement increased significantly, and those who agreed, that proportion decreased significantly. Factors associated with perceived stigma included things like being HIV positive, of course, and not knowing another person who was HIV positive. In conclusion, the social scientists across the trials would like me to convey to you that stigma is not the only thing we're researching, and we don't think it's the only thing that's important. However, in these findings related to stigma, I'll make some broad conclusions. There were heterogeneous levels of underlying stigma at baseline across the trials and even within trials across settings. The implementation of test and treat and the uptake of test and treat interventions was hampered by stigma. Aspects of interventions that accounted for stigma or responded to stigma really facilitated test and treat. There is supportive evidence of declines in stigma in some settings, and evidence of the plausibility that test and treat could accelerate what would be secular declines in stigma because of increased testing, because of increased treatment coverage via specific pathways. And future efforts should really tap this synergy of test and treat and stigma reduction. I want to thank all of the social scientists working across the trials who entrusted me with presenting their findings. It's been a pleasure to work with all of you. And I want to thank the study participants, my fine collaborators in search, and the participants, funders, and organizations supporting this work. Thank you.
Thank you very much. Any quick burning question for clarification? No, thank you. We are really running a little bit late. We started the session a little bit late because the previous session I think was very interesting. But I would like now to move on to the panel. This is where it gets very, very interesting. I like the panel. Pillay. I'd like to have Helen. I'd like to have Diane. And I'd like to have Lefeletwe come up very quickly. And Fiona. So get your questions ready. Be very precise. But just to be sure, I would like each one to very, very quickly introduce themselves so you know whom you're going to introduce, which question you're going to send to who. Very, very briefly to introduce themselves. I'll start with Fiona.
Hi, I'm Fiona Walsh. I'm a co-investigator on the MaxArt trial.
Refeletwe Belonyane from BCPP, co-investigator.
Dinan Pillay, co-PI of the TASP trial.
Good morning, I'm Diane Havler, a co-PI of the search trial.
Good morning, I'm Helen Ailes, and I'm the Zambia PI for PopART.
Great. Helen, hold on to the microphone. So, I can see Wafa is ready to go. Okay, Wafa. No, we don't hear you. Yes, that's better.
Yes, thank you very much, Wafa Al-Sadr from ICAPA Columbia University. Thank you very much for sharing the information, especially the details of the designs of the different studies. I have a question regarding the primary outcome and how it's measured in each of the studies. I recognize that all of them are community randomized, and all of them are, or several of them, have HIV incidence as the endpoint. But who did you sample in order to measure incidence? Was it in the whole population, in a random sample of the population, random sample of households? And what were your comparisons in looking at incidence in the intervention versus control arms? So,
Wafa, I assume each one of you want each one of them to respond to this question.
I think it would be helpful.
Yeah.
As we anticipate hearing results tomorrow, it would be helpful.
Very good. Helen, start.
Okay, so in the PopART study, we took a random sample of about 2,000 individuals from each of the 21 study communities. And those individuals were aged 18 to 44. And so our measure of HIV incidence will be in those individuals who were HIV negative at baseline, followed for a period over 36 months.
Diane?
So in our study, we actually did a measurement of everyone, not a sampled measurement of our population from baseline, those individuals that were 15 years of age or older and HIV negative at baseline. And we did cumulative 3-year incidence, which was rapid testing confirmed like by Genius or Western blot.
So in TASP, it was the whole eligible population in the trial who were tested, recruited to testing 6 monthly, and incidence was based on that for the whole population.
The whole population, okay.
In BCPP, we had in both arms, we had a cohort, HIV incidence cohort, but at the end of the study, we did end of the study survey in 3 pairs, both in intervention and in control.
Okay. Fiona's study was not presented, but I don't know. You'd like to say something about it?
Sure, I'd be happy to. So our study was a different design. It was a stepped wedge trial, and we didn't measure incidence. Instead, we looked at retention and viral suppression.
Okay. Yes, please.
Yes, so I have just 2 observations that I'd like just to hear the panel react to them. The first is that, when we were at UNAIDS and coming up with the 90-90-90, we realized that it had great strengths because it goes from diagnosis all the way to viral suppression. But we also knew that it had a major weakness, which is the floating denominator that you have to use with the 90-90-90. And so I see presentations in our papers we've struggled with that use Cascade, 90-90-90, and these sorts of things. And so I would suggest that to get the language as close as possible I would not use Cascade and 90-90-90 in the same sentence. I would actually, I would suggest that we use Cascade, Cascade, which actually starts with the people living with HIV, and then what happens with all of them. 90-90-90, I would, at the risk of being pilloried, is more of a surrogate measure on how the country's doing or how the program's doing, but it is very difficult for people to comprehend. I would use it, but I would, in research trials, I would definitely be thinking about Cascade, the number of people that are living with HIV as your denominator. That's the first observation. The second one, if you allow me, is that it's quite interesting to see the trials together. This is awesome. I can't believe that you guys have been able to achieve this and you're sharing data, et cetera. And now we have the opportunity, and I would say not to look at whether TAS works or not, because I think that treatment does work to stop illness, death, and transmission, but to look at actually how is it best to deliver this into the community. And you can see that by the different trials and the successes that they're having, that is actually what we're seeing here. So thank you very much.
Thank you very much. Does anybody want to respond on his suggestion of how to talk about how to present the data, not to too much focus on the 90-90? Yes, Helen.
This one's working, but thanks, Ruben. Yeah, I would agree. I mean, really, you designed them more as advocacy tools as well. I mean, I think it's a really bad indicator, that first 90, because it's not measurable, and you have to do all that modeling and working out what your real baseline is. And so, I think we do have the power, obviously, to look at the cascade and to show that. And I think that is a powerful thing. I think we have all tried to look at the 90s so that we can compare with what's going on in the rest of the world. But, you know, I totally agree with you.
Yeah, sorry. Do you still have a follow-up question? I still have people lined up.
I think you should measure the first 90. It's just that you should do it in a Cascade versus 99.
Right, point taken. But I like also to follow up on the point that all these 3-4 trials have been able to put together. There was a time when STIs were very sexy, and there were so many trials on STIs that were going on, but we never had a chance to have all the clinical trials sit together and compare. But we did eventually. We did eventually. Yes, Kevin.
Hi, Kevin Lecoq, CDC. Without going into the theology of 90-90-90, I guess they should be described as ratios rather than rates. And what we really need from treatment programs is cohort analysis, like we have for tuberculosis. And another problem with 90-90-90 is we forget that people die and ignore mortality, which remains a huge issue. But anyway, my question actually was really, I think to PopART, I don't know if it's relevant to the other trials, in the opening talk, it was mentioned that self-report of HIV negative status was accepted as a piece of data. In Kenya, the predictive value, the negative predictive value of an HIV negative self-report is actually very problematic. In the AIDS Indicator Survey in 2012, something like 30% of people said they were negative were actually positive. And if you look at people who say they're negative and test their blood for antiretroviral metabolites, it was remarkably high. About 20% of people who said they were negative had ARVs in their blood. So you have a potential there for misclassification, and I don't know whether that's an issue, if it's a big issue for your trial, or whether it's an issue at all for any of the other studies also, but I'd like to hear your comments.
So Helen, have you been able to validate the self-report and serostatus?
So I think there are various issues here. So Kevin, yes, we use it for coming up with these 90 estimates. But of course, we don't use it in our real measurement for the trial because that's all done on venous blood sampling, and so is not at all on self-report. So, this is really when you're in the household with somebody and they tell you, I tested HIV negative. It's difficult, according to national guidelines, to really encourage them to test again. But then, of course, we'd be going back to that household again in a few months when we'd be offering testing again. So it's slightly artifactual of putting it here as a problem. I don't think it's a problem. It's really reflecting real life. But to calculate to report these 90s, we allowed people to say they had tested negative in the last 3 months to say we had a status on them. But it's a little bit artifactual.
Nancy, I'll give you all the time for your questions.
Well, that's great, David, because in fact what I'm going to do is ask a question that I heard you ask, which I think was a very good question. And that is, it's a BCPP question that I should know the answer to and don't. And it was mentioned that there was a lot of, all of the studies had the problem with in-migration and out-migration. In Botswana, I believe, and you should correct me if I'm wrong, that treatment is not available if you're a foreigner. Is that true? So the question is then, therefore, did those people not show up in your denominator either?
Can I have that microphone over? Oh, you have one right here. Okay, sorry.
Yes, treatment is not available free for this for immigrants, and yes, we took them out of the denominator.
They were out of the denominator?
Yes.
Okay.
Is that all, Nancy?
Sorry?
Is that all?
Oh,
thank you.
I'm giving someone
Next
else
question.
a chance.
Hi, I am Sara Van Rompuy and I work for Friends in Global Health in Mozambique. And my question is related to the control sites, especially the first 90. Did it improve a lot over time as well?
You're asking everybody on the panel? Okay. Helen.
I think the answers are very quick, because we don't have that information yet because we haven't unblinded in PopART.
Tomorrow, you'll hear.
Yes, and I think one of the important things that came out of the presentation were those secular trends as well that go on over the period of time. Clearly there's a big rollout campaign, and guidelines are changing anyway.
Yes, a quick one. Yes, it did, but of course, in the intervention, we saw more.
Okay. Maybe. Yes, please.
Thanks, David.
Yes, to the Cascade again.
I'm asking again sort of about measurement and ascertainment of various outcomes. So for HIV incidence, it's tricky in the sense of, like, I recall, Helen, you said in each of your communities you followed 2,000 people. But I can imagine that of those 2,000, some died, maybe 10%. Some were lost to follow-up, another 10% maybe. And others, maybe you found but didn't succeed in actually testing. So where is all that going? Because again, there's no right answer to this, in my opinion, but the numbers can jump around quite a bit depending on decisions, and in terms of even aligning and harmonizing the results from our different trials. If the decisions aren't the same, we can have artifactual reasons for differences that are reflecting underlying, maybe not so different experiences. And similarly, in the on the last 90, I saw things like on ART. So does on ART mean has been initiated on ART? Does on ART mean there's a record of the person having been to the clinic and received new medications, say plus or minus 2 months from the current visit? Or does it mean that the person was actually tested, which I think in one of these trials, it might have been search, you actually confirm presence of ARV in the person's blood at the time you see them, which, in my view, would be the only way to really know, if you want to call it on ARV. That's the only way to know that. I mean, I can tell you in MaxArt.
I have a long line behind.
Yeah. Okay.
So you're basically asking to what extent is this comprehensive? I mean, there are many people that are lost to follow-up who are died. Basically, Kevin's question, I wonder if any of the trials were able to see in the first 90, if you lose people in this, what really happens to these individuals?
Maybe just to make some general comments, no one starts doing trials of 300,000 to 1 million people without thinking about this and discussing this for hours, if not days and weeks. And I really want to compliment my colleagues who have really thought this through for their particular trial and what they did. And I'd also like to say that, for example, for mortality, we really have very rigorous data on mortality. It's not that we just forgot about mortality. We have very rigorous data on loss to follow-up, and each of these trials has pre-specified analysis of exactly how that they are dealing with the important issue that you raise. And that's the beauty of this consortium that Richard has put together, that as the trials all mature, we'll be able to harmonize. So I think people can be rest assured that your questions are bringing this up. The trials have very rigorously addressed, and as we start working together, that we will be able to deal with that issue. I'm sure each of the statisticians of the trials could be very specific, but I think that's like the broader response.
All right. Okay. The lady, yes. Hi.
My name is Anke Groet. I work for AIDS Fonds, for the Sex Work Department. My question relates to the involvement of key populations. In which way the trials ensured that sex workers, the LGBTI community, and people who use drugs are reached?
To some extent, I think they reported that they did not involve key population. Is that correct?
I think we probably want to clarify that all of us were very inclusive, and I think in multiple presentations, we included everyone into the outreach of these trials. And for example, in some of the areas where we work, people do not self-identify as, for example, a sex worker. And we did outreach in order to make everyone feel inclusive to offer the services. So I think I'd love for my colleagues to answer that, but that was, and certainly in search, it was not just about HIV, it was for your overall health. So maybe one of the other trials could answer. Maybe Helen?
Key population?
I would agree. We were trying to reach everyone and everyone who was living or working or being in these communities. So that was whether they were a self-identified member of a key population or whether they weren't, or whether, so we did have some specific strategies for different groups, but I think our aim was universality, everyone.
Anyone wants to add on that? Okay, I'll take a question from the lady here.
So it was really interesting seeing the cascade by gender and by age, and the sort of reflection that essentially the younger groups were more difficult to reach in all the trials, albeit with different variations in terms of the viral suppression. And I just wanted maybe the panel to reflect on that in terms of both STIs being more common in that age group and sex being more common in younger age groups, and how they think that might be impacting on trial outcomes, and also reflecting on things that helped make that better over time.
All right. Anybody wants to try?
Well, we recognized early on that we were really not addressing the youth as well, and we actually did have a separate ancillary study that really focused on young people. And of course, again, it's very tricky when you show it in these cascades because, again, these are dynamic populations. So people who were in one youth group, in the youth in 1 year, the next year they're not, they're in the next box up. And so again, I think it's very challenging, but we worked very hard to really make this intervention work for young people.
So thanks for the question. I think globally there's no doubt we need to do better in youth. And I think the trials showed that for testing, all the trials made great progress on testing. But for those of you who work in the field, one of the gaps you can see as you look, even in this very limited way, but helpful way, when youth get on therapy, staying on therapy is a big challenge. And it's not because the youth has a problem, it's because we have a problem with the systems we're offering the youth. And I think this is an area we really need a lot more innovation on, working together as a field. Because even though we got better, we are nowhere near where we need to be with youth.
So I'd just like to confirm that sort of the interest of that analysis, of those analyses. And of course, we will, as part of this consortium, be wanting to know what are the drivers of ongoing incidents despite the intervention. And of course, being able to stratify by a whole range of different factors, I think will be one of the things that will then allow us to come to the next series of trials which target, to really eliminate HIV.
All right. Lefeleru, you want to say something?
I think, like my colleagues, this is the first phase, but there's still a lot that we have data that will still be analyzed definitely to answer some of these questions. But issues of the youth, yes, there are some of those gaps that we need to address.
Great. In the interest of time, I'll take the last two questions back to back, and then we will close the question. I'll have my last question, but the two questions back to back, and then the panel will answer.
Thanks very much. Dennis Nash from New York City. So, of course, it's very encouraging to see youth getting on treatment and staying on treatment. I'm wondering the extent that each of the trials was able to assess the degree of immune deficiency across the communities at diagnosis and at treatment in the intervention stage. It speaks to, I think, the potential for impact of test and treat on incidence, but I didn't hear it discussed in any of the presentations.
Okay. Second, Derek.
All right, I'm Skatele Mazvuo from Swaziland. I think mine was a concern and then a question. I'm really concerned about the Botswana study, especially looking at the access to services for immigrants. There's a huge disparity, but somehow I think we're just glossing over it and not actually addressing it. I don't know, from the people in the country, is there anything being done for that population? Because to me, they're starting to look like a key population. And maybe just to ask, if someone is not a citizen of Botswana, do they pay tax or they don't pay tax? And if they do pay tax, do they then have access to certain things because they are taxpayers as well?
All right.
If we just get clarity on that.
Thank you. Okay, first question was assessment of the immunity over time.
I think if I understood the first question, we did measure CD4 at baseline, and so we will have analysis when we're presenting tomorrow, putting CD4 into context of what happened during the trial.
All right. Botswana, do they pay taxes? Don't they pay? Why aren't they included?
Yes, this is a concern, and it's something that is in the in the table that is being discussed for us to be able really to achieve epidemic control. Unless that group is addressed, we might not. As much as we are doing well, that is a concern. We should understand that Botswana Botswana actually has been paying for their HIV response, even the treatment. So they started first with the locals, but it's something that is being looked and it is being addressed at regional level. They have taken up to the regional level that countries in the SADC, we should really contribute towards that, have that one where we all contribute so that people, as they move around, they can access treatment. But it's something that is on the table that is being discussed as I speak.
Right. So I'll ask the last question. And I'll start with Helen, but everybody will answer the question if possible. So these are very huge trials conducted over a period of time. It requires quite a lot of time and effort, and really would like to thank the participants here for leading these very important trials. But I would like to ask each participant, and I'm sure their views have evolved as these trials have have progressed. What is the thing that really struck them or they have learned? What would be your takeaway message in these trials? And I'll start with Helen.
So what I think I've learned is I've been just amazed at the changes in the communities over time. When we first went into the communities, we were, greeted with a degree of suspicion and skepticism from the community. And, if you walk into the intervention communities in Zambia where I work now, the whole attitude about HIV testing, the whole attitude about knowing everybody's status and the demand for condoms, for example, that's, as soon as you walk in wearing one of our uniforms, you're sort of almost mobbed, is amazing. I mean, it really just shows how the power of the change of communities.
You can feel the change, okay.
So I can answer it for our intervention arm, not for our whole trial, but what I can say, I would say two things. I'm going to build on what Helen said. The power of the community search was a very community-led trial, as opposed to saying when things don't work, then we go to the community. The community solutions of this multi-disease approach were from the start of the study. That was number one. And number two, one can rapidly scale up ART, which you saw across these studies in a very short period of time, working hand in hand with the community with these different models.
Pile?
So I can speak now that we've reported our results, and both to reaffirm the importance of working with communities in which you're undertaking the studying, but at the higher level of an approach to HIV prevention, I think what we've learned is that there is not one way to reduce HIV prevention. Our trial was focused very much on one approach, which was testing and treating, and I think we just need to be far more flexible, have more options for prevention, and combination prevention will be the next focus.
All right. Philip.
What I can say is what we have really maybe is a take from here is all of us from the baseline, the challenge has been the youth and men. But if you really design programs that specifically target them, and you go to the places where you will find them, they will not come to us. But if you go to them, they really, in terms of declining to test, they do accept the test, and once you put on treatment, they do. So we need to be more innovative of really how do we provide the HIV, the services, not the traditional way of expecting them to come to our facilities.
All right. Fiona, any perspective you would like to share with us?
Sure. So I think from MaxArt's perspective, I would say I think on behalf of really the entire consortium, the thing that we've taken away is just the level of commitment and willingness from the government of Swaziland, or Eswatini as it's called now, to really look at new approaches and ask the tough questions. I think when the results from HPTN 052 came out, there were a lot of real policy questions around differences in cost and acceptability, the ability of the facilities to be able to actually absorb the additional clients. And I think in Swaziland, we've really had an opportunity to work very closely with the ministry who led our trial and really ask these questions and work to answer them so that they could use them to inform policy.
All right, there you have it. I would like you to join me to thank these panelists for sharing their effort of many, many years. Richard, you want to say anything?
Yes, please. If I can just take 2 minutes. Firstly, I want to again thank the panel members for joining us on stage and sharing some really interesting perspectives and answers to the questions raised. I want to thank the audience for staying with us. I know we started a bit late, and I hope you'll still have time for lunch. But I wanted to just say I was hoping you'd ask me what lesson I'd learned, actually. Because I learned a very important...
I'm sorry, Richard.
No. I learned, I think, a very important lesson many years ago. You touched on it. Many of you are too young to remember this, but about 20 years ago, we had a similar situation with a number of trials that were looking at a very similar intervention. This was based on STD treatment as a means of bringing down HIV. And I was the PI of one of those trials, and in fact David was a PI of another of them, the RACI study. They found very different results, and it actually left the whole HIV prevention community in some disarray, I would say, for some years. We did manage eventually to bring together the PIs of those 3 studies, and we did what I think in retrospect was probably more important than the original trials, which was to work together, bringing together all our data. And I think by doing that, in the end, we learned some very important facts about the HIV epidemic and about the epidemiology and control of both STIs and HIV. So when we set up this consortium, I very much had that in the back of my mind. I'm sure we will need to do the same thing with these 4 or 5 studies. They are sure to find different things, but in understanding the results of those trials, I'm quite certain that we will learn some very important things about HIV control in these different settings. So I'd like to thank personally all the PIs of the 5 trials for their collegial attitude in joining together in this consortium. I think we've built a really good working group together, and I'm looking forward to working with you all over the next probably 2 or 3 years as we work on the results from these studies. I just wanted to again thank the 4 speakers. They had a really hard task. I mean, in most talks, you're talking about your study. They had to try somehow to bring together, you know, the results from these very different studies and make sense of them and present them in a comparable way. And I think they did a really good job of that. So many thanks again to them. And finally, I just wanted to re-advertise 2 other sessions. One, which I'm sure you won't miss, is tomorrow morning at 11 o'clock in the big hall, when we'll hear the primary results of 3 of our studies. We're really looking forward to that. And then this evening, if I hope you'll still have lots of energy, at 6:30 p.m., we have a kind of sister consortium, which is the social scientists working on these studies. And they have a symposium, I think it's around mobility and the effects of that on HIV control in the context of these UTT studies. So please come along to that at 6:30. Now it's lunchtime. Thank you very much for coming.